So here we have very interesting X-ray of the chest. Now this X-ray chest is in the PA view, which is visible here, that it is PA view. Now when we try to see findings, there are so many very interesting findings, of which we can say is that the most important thing which we should always see is the trachea. If you can see here, this is the tracheal margin. So you can see that the trachea is here, the trachea is here. So this is the tracheal margin which we can see. So we can see that the trachea is like this, and the trachea is deviated here. So it is in short shifted to this side. If you can see the upper area of both side of the lungs, then we can see this. There is a very nice dome of the lung which we can see on the right side. But in here, this dome here is not at all there. In fact, this much area, there is a radio opaque structure which is there, which is basically displacing the lung. So lung is in short starting from this area, which should have been from here. So there is a soft tissue structure or a thing which is basically replacing the lung here. So if it is a solid thing, it should simply have pushed the trachea to the right side, but in here exactly opposite has happened. This the thing, the upper right lung area has something which is pulling the trachea towards this side, and there is only usually one thing which pulls the trachea to the same side, and that is fibrosis. So fibrosis very commonly pulls the mediastinum or the trachea to the ipsilateral side. So here what we have is fibrosis, and we know that the most common disease which very commonly affects the upper portion of the lung is tuberculosis. As we know that tuberculosis loves oxygen. It is a aerobic bacilli, aerobic bacteria, and it loves oxygen, and the upper portion of the lung is full with oxygen. That is the reason why this is the most common site for the tuberculous bacteria. Same is with nocardia also, because nocardia also very commonly loves oxygen, and upper portion of the lung or upper lobes of the lung very commonly is full of oxygen, full of air. That is the reason why this is the most common site. So one thing we have seen is that the trachea, not only trachea, but the mediastinum is shifted or is pulled towards the upper portion of the left side of the lung, because there appears to be fibrosis of upper portion of the lung, which is causing pulling of the mediastinum and pulling of the trachea to the ipsilateral side. Now, this is backed by some other findings as well. As we can see when we zoom in, we can see a very discrete, multiple, hyper dense or a radio opaque nodular patches or nodular lesions in bilateral lung fields, not only in unilateral, but we can see it in bilateral lung fields. Now we know this type of nodular patches in bilateral lung field is very commonly seen in either malignancies with metastasis, but in metastasis this type of patches will not be this much ready opaque. This will be more of a soft tissue lesion like this, as this is a soft tissue. This is a part of liver, diaphragm, this is part of fat. So this type of nodules will be there in metastasis, and usually mets will have at least one large lesion followed by multiple satellite lesions. So the size of the nodules in the CA lung with metastasis, it usually varies for more than maybe around 5 millimeter. But in here, what we are seeing is very small, discrete lesions in bilateral lung fields. These are nodular, discrete, and this appears to be calcification post-infection. So whenever there are multiple infection focuses, these get secondarily calcified and then they appear dense white on X-ray. So this patient actually had history of tuberculosis and he had completed tuberculosis treatment 3 years back, and this actually is supported by the presence of fibrosis in left lung field with tracheal shift, mediastinal shift, and multiple calcification in bilateral lung fields, which is very very characteristic of an old recovered infection. So if the patient has bilateral calcifications, you should always think why there was so much extensive infection in the lungs. Maybe if an immunocompetent patient doesn't have this much of extensive bilateral calcification. So as there is extensive bilateral lung parenchymal involvement, you may think of immunosuppressive state. And yes, this patient was retroviral disease positive. Means this patient had AIDS for which he was on antiretroviral therapy. So that actually sums up everything, that a patient who had HIV, who had immunocompromised state, who had tuberculosis, with that tuberculosis was involving bilateral lung fields that caused the lung fibrosis, multiple lung lesions, calcification, and now presenting with this type of typical lung feature. So there is one more thing which is remaining here in this X-ray is presence of this effusion. If you can see this angle, this costophrenic angle, this is the diaphragm, these are the rib margins. This costophrenic angle is pretty clear, so there is almost no pleural effusion on the right side. But in here, this angle is blocked, and there seems to be a very, very minimal left-sided pleural effusion. So this is all about this. There's one more thing that is remaining. If you compare the lung parenchyma, if you can see, this is the lung parenchyma on the left side, which appears pretty less compared to the lung parenchyma on the right side. So if we compare this much volume with this, there is significant extensive damage of the left lung. That is the reason why there is loss of volume of left lung parenchyma. That is the reason why left lung appears smaller in size compared to right lung, which is compensatorily increased in size. So this is all for now, and thanks for your listening.